So Module 1 includes chapters 1 through 5 in your F.A. Davis textbook, as well as chapters 1 and 11 in your ATI textbook. And we're starting with chapter 1, Issues and Trends in Pediatric Nursing. Nursing care of children occurs from birth through adolescence and includes health promotion, disease prevention, illness management, and health restoration. It can sometimes extend beyond adolescence. As a pediatric nurse, you might take care of patients that are 18, 19, 20, and beyond because they have complex medical issues that requires constant care from a certain pediatric specialist. For example, I personally took care of a 37-year-old woman who had a rare form of childhood cancer, and so she continued to be treated at Phoenix Children's Hospital. So you might not just be taking care of children, you might be taking care of adults as well. Pediatric nursing does require the nurse to use both assessment and evaluation tools that are unique to infants, children, as well as adolescent populations. Your approach as a nurse to an infant is going to be a lot different than your approach to a teenager. For example, if you're going to start an IV on an infant, you are going to obviously have to explain the procedure to the caregiver, and then your techniques at getting the IV in is going to be focused on a lot of distraction and soothing for the infant. Whereas if you're going to start an IV on a teenager, you're going to want to explain the procedure to the teenager, how it works, and then potentially use some sort of lidocaine to numb the area, and then just answer any of that teenager's questions regarding that IV start. Pediatric nurses must assess attainment of developmental milestones. There are quite a few developmental milestones throughout infants, toddlers, preschool, school age, and adolescent populations. So as a pediatric nurse, you do need to be familiar with them. Pediatric nurses also monitor growth and development, including physical and cognitive maturation. As children start to grow up, their height and weight requirements change, their vital signs change. So as a pediatric nurse, you need to be familiar with the ranges for those specific ages, which we'll go over a little bit later in Module 2. As well as the role of development. So peds isn't just caring for little adults. Their needs will vary based on their developmental level. And in pediatric nursing, you're not just caring for the kiddos, you're caring for the children and their caregivers, which adds an extra layer to it. Pediatrics became a specialty in the hospital. Newborns were delivered by midwives and were actually cared for in the home as opposed to the hospital setting. The first pediatric hospital in the United States was founded in 1855 and was the Children's Hospital of Pennsylvania. As early hospitals became more industrialized, the following were common practices in both infant and child care. Nursing care was more focused on preventing the spread of infectious disease and was often very cold, very rigid. Parents were unable to stay or visit the bedside of their children, which relinquished all care and responsibility to the nursing staff. Including the family in the plan of care was believed to be detrimental to patient outcomes. So the parents' opinions, thoughts, concerns for their children was not taken into consideration when the healthcare team created plans of care for their pediatric patients. And the emotional and psychological needs of children were not considered in care planning. So their developmental status, their emotional state, how they might react to certain procedures or treatments was not taken into consideration. Which, if you think about all of these things, it's definitely not what a productive pediatric facility sounds like. So as time went on and more research was conducted, the negative effects of separating the parent from the child, as well as the cold approach to healthcare, became much more apparent. This research actually helped influence the development of both family-centered care as well as advanced practice roles for nurses. So in the pediatric realm, that would look like the pediatric nurse practitioner or the neonatal nurse practitioner. The nurse practitioner role was actually created by Dr. Loretta Ford and Dr. Henry Silver in the 1960s in order to increase patients' access to pediatric care. So pediatric nurse practitioners were amongst the first NPs to exist, which I find pretty interesting. In pediatrics, there are several models of care that prioritize providing safe, quality care to patients in both the inpatient and outpatient settings. In pediatrics, the importance of the family is emphasized because caregivers are representing their children. They are their voice and their advocate, and in many cases, the caregivers know more about their children than us healthcare workers do. So it's really important to consider their thoughts, their concerns, and their own expertise when we are planning treatments, as well as their plan of care for the day. Some of the core concepts of family-centered care include the following: providing dignity and respect for the child and family, informing and thoroughly communicating with the family. And this goes for every member of the healthcare team, not just nurses. So providers, respiratory therapy, physical therapy, occupational therapy, etc. We've actually started shifting to a bedside report in a lot of children's hospitals and certain units. So this means that instead of night shift and day shift nurses giving report at the nurses station, we do this at the bedside so that the family can add in their thoughts overnight / during the day, their concerns. Now, not every unit in the hospital does this. When you guys have your clinicals at Phoenix Children's Hospital, you're going to see some areas do this and some don't. It just kind of depends, but we are trying to shift to this bedside report model. We want to allow the family to participate in care as much as possible. We also want to include them and collaborate with them when we're care planning. This goes to including them in rounding. So in a lot of hospitals, we'll have inpatient rounds. So we'll have the doctor, the nurse, the charge nurse, the pharmacist, the social worker / case manager, if it's a teaching hospital, any residents or interns or medical students. And we really want to encourage family participation in these rounds so that they can be included in what's going on. They're up to date with what's going on, and they're able to express their concerns to the team and make sure they feel heard and seen. And lastly, we don't want to ignore the family when we go into patients' rooms. We want to introduce ourselves to both the patient and the family so that they feel included. Our next model of care is the relationship-based care model. And some of the core concepts of this include that the child and the family remain the focal point in the plan of care. As the nurse, we want to strive to develop a relationship with the child's family members and engage in one-on-one conversations with the family and the child on each shift. We want to strive to respect, understand, and address the child's and family's concerns. The children and the families are actively engaged in all aspects of care, including decision-making as appropriate, have open communication, and have the child's well-being and dignity be safeguarded in all aspects of communication and care. So those are some of the core concepts of relationship-based care, which is very similar to the family care model. It's just more so focused on having that open line of communication. Our last model of care is the Pediatric Medical Home Care Coordination. The core concepts of this model include having care coordination throughout the hospital stay. This includes hospital discharge to primary care, as well as referral from primary care to community services for additional non-medical needs. So this might be things like seeing a therapist or getting financial assistance, getting transportation to and from doctor's appointments, things like that. When caring for children and their families, the pediatric nurse must assume several critical roles. They must incorporate knowledge of human growth and development when providing care to children. They must recognize the physiological differences between children and adults. They must provide care in a developmentally appropriate manner to promote the optimal physical, psychological, and social well-being of the child. And as a pediatric registered nurse, there are a lot of different avenues where you can work. You can work in children's hospitals or hospitals that have pediatric units, pediatric home health facilities, outpatient clinics, school nursing, inpatient or outpatient surgery centers, and IV infusion clinics, just to name a few. Pediatric nurses with their master's or doctoral preparation are often employed in the following settings and capacities: nurse practitioners, nurse educators, nurse managers, nurse anesthetist, just to name a few. And if you're not looking to go back and get your master's or your doctorate degree, pediatric nurses at all levels who wish to further specialize in their careers can obtain additional certification in many practice areas. For example, the CPN, or Certified Pediatric Nurse Certification, is a very common one that peds nurses get. In order to get this certification, you have to have worked as a pediatric nurse for 1 year. And then you have to take a course as well as pass an exam in order to get this certification. While not every hospital or facility will give you a raise or do anything special for the certification, but it does look good to have on your resume, and it does if you are looking to move up and be a clinical supervisor or have some sort of leadership role. Having a certification like this does look really good. Nurses considering a career in pediatrics must become familiar with common issues in this area of healthcare. One of the most prominent ones being the expected nursing shortage. In general, there is an expected nursing shortage in the United States due to an aging population and many nurses nearing the age of retirement. This shortage will impact all areas of nursing, including pediatrics. Another common issue in pediatric nursing that we see are research projects. One of the issues that we see is children that can refuse to be in research projects. Children aged 7 years and older can assent, agree, or disagree to be in a clinical trial. This means that even if the caregivers want the child in the research study and sign the consent, the child can refuse and the researcher will not include the child in the study. This does limit the amount of children that we are able to have in clinical trials. In addition to this, the lack of research studies using ethically and culturally diverse populations is present, meaning the clinical indications and findings from that research that are used on everybody are only being tested on a very small population, very specific, very small population, which is unfortunate. Some of the other issues that are involved in pediatric nursing include continuity of care. So as the number of chronically ill children continues to increase because of medical advances, continuity of care between hospital, home, and school must improve. Children are now exceeding previous life expectancies for chronic illnesses, but still require ongoing medical management. So we need to improve our continuity of care between inpatient and outpatient settings. Maintaining communication with families and caregivers has become more challenging with the increased number of divorced parents, blended families, grandparents as primary caregivers. Pediatric nurses must also consider the special issues in working with foster parents, extended families, single parent families, LGBT families, as well as families with adopted children. An example of this would be you're taking care of a pediatric patient that has foster parents. As the nurse, you must figure out who is responsible for signing consents, because a lot of the time the foster parents is not able to sign a consent form. That responsibility would fall on either Child Protective Services, who has custody, or in some cases even the biological parent still has the authority to sign consents. Other issues include ensuring adequate health education and follow-up services for children and families. As a nurse, it has become more challenging to provide that health education, especially those that have limited health literacy or English is not their first language, or if they don't speak English at all. And last, healthcare costs is a very large issue in pediatric nursing. It's a large issue in healthcare in general, but it translates to pediatrics as well. As healthcare costs continue to increase, families' adherence to recommended therapy and treatments may be negatively affected by having little or no health insurance. Underinsured or uninsured families may be unable to afford follow-up care, which will definitely impact their health and well-being as time goes on. Pediatric nurses should be aware of existing trends in this area of practice and consider how these factors may impact their roles and responsibilities. Some of these trends that we've been seeing in pediatric nursing include the following. We have an increased number of children who require mental health services. This is especially present after COVID-19. An increased usage of blood conservation techniques for hospitalized children. An increased incorporation of families in the overall care of children. An increase in admissions based on deficit knowledge base, such as caregivers not understanding or following the treatment regimen correctly. An increase in admission based on lack of primary care access. And an earlier onset of puberty and its ramifications for adolescent sexual health. So those are some of the more common trends. Other trends that we see an increase of are going to be obesity, high blood pressure, diabetes, and asthma. We also have seen an increase in children and adolescents who identify as transgender. And as the pediatric nurse, it is your responsibility to promote health and wellness in these individuals by asking the client what name and pronoun they wish to use. Recognize that this population is more at risk for depression, bullying, and discrimination, and providing clients with care that are both respectful and inclusive. Nursing is a highly trusted profession. According to the latest annual Gallup rating of various professions, nurses lead the nation in ratings for honesty and ethics for the 20th consecutive year. This is largely a testament to the relationships nurses develop with patients and their families, as well as the principles, values, and standards by which they aspire to conduct themselves. The nursing profession has a code of ethics, which we hold ourselves to. The codes of ethics and standards of practice and professional performance serve as benchmarks of quality and accountability, as well as providing protection for the public and guidance for the professionals. Pediatric nurses must also develop an understanding of basic principles of ethics and consider the types of ethical dilemmas they will likely encounter in nursing practice. They'll have to understand the process for resolving ethical issues and know the resources to consult when ethical issues arise. Just like with any area of nursing, peds nursing has a specific scope and standards of practice that it adheres to. The ANA has the Pediatric Nursing Scope and Standards of Practice 3rd edition book as the definitive and primary source of its standards. An example of a standard of care in pediatrics is obtaining informed consent from parents prior to a procedure for a child. This differs from adults because adults can obtain their own informed consent. In pediatrics, the legally authorized representative is the person who obtains informed consent on the behalf of the child. Now, this is typically the parents or caregiver. However, in other cases, it might not be. For example, if a child is under DCS or Child Protective Services custody, it will be the responsibility for DCS to obtain that informed consent. In pediatrics, as in other nursing specialties, the relationship formed between the nurse and the patient and family provides the framework for care delivery. Professional boundaries must be respected, but at times can be difficult to define. Therapeutic relationships are respectful, caring relationships between the patient, family, and the child's nurse that are bound by ethical and professional boundaries. Infants and children are innately vulnerable, and this vulnerability increases when parents or guardians are not present or if they're unable to participate in the child's care. This inherent vulnerability may lead the nurse to either distancing or even over-involving themselves, especially in cases that involve children who are abused or neglected. Nurses should avoid judging or labeling families and instead use assessment skills to determine the roots of the problematic relationship. This will help reduce the impulse for us or the nurse to take the patient or family's behavior personally, avert a defensive response, and help the nurse maintain compassion. Family-centered care really incorporates the family in all aspects of the child's care and can be extremely beneficial to the well-being of the child. Some of the benefits that we see from utilizing family-centered care include a reduced likelihood of medical error, a decreased disruption of normal patient-family routines and responsibilities, and an increase in patient and family satisfaction. Another aspect of family-centered care is tailoring our healthcare to the child's developmental stage and need. Child life specialists can help us in this area. If you aren't familiar with what a child life specialist is, this is a role specific to pediatrics. Child life specialists assist in preparing children and families for and supporting them through procedures. They also help the client as well as their siblings. Child life specialists provide therapeutic play and self-expression opportunities. They help design and maintain child and family-friendly environments. And they work closely with other areas like art and music therapists, as well as act as liaisons with the hospital and community-based teachers. Providing developmentally appropriate care is one of the main roles of a pediatric nurse. Children will differ from adults in their physiological responses to pain, their ability to describe or quantify their pain, as well as their tolerance of and their response to pain medications. The way you assess or treat a child's pain can vary based on their age and development. An infant is not going to answer the question, "Can you tell me what your pain is on a scale of 1 to 10?" So as a pediatric nurse, we need to ensure that we are utilizing the correct pain scale for the patient based on their age and their development. Two of the most common pain scales that we have for pediatric patients are going to be the Wong-Baker-Faces pain rating scale and the FLAC scale. The FLAC scale is used for children who are not able to verbalize or speak. Typically, we use it for ages about 6 months to 2 years. However, for our pediatric patients who are developmentally delayed or nonverbal, we may utilize this scale after that. This scale uses objective findings to identify what the patient's pain rating is out of a 10. As you can see on this slide, the bottom right corner, we have 5 different sections of the FLAC scale. So the face, legs, activity, cry, and consolability. So when you're looking at the patient, you're looking at their face. Do they have some sort of scowl or, kind of clenched jaw? Do they have a frown, or do they not really have any sort of expression? Their legs, are they legs kicking? Are they drawn up, or are they in a normal relaxed position? Activity, are they arched? Are they jerking? Or are they lying quietly, moving? Are they crying, or are they not crying? Are they able to be consoled easily, or are they not? Answering those questions, giving each area a 0 or 1 or 2, will give us our FLAC scale. You guys will be utilizing this in your pediatric lab course. The other pain scale is that Wong-Baker-Faces pain rating scale. Now, this is used for children that are a little bit older, typically older than 2 to about the age of 7. However, it all depends on the child's developmental level. If the child isn't really able to talk, they're not going to be able to utilize this FACES scale. With this scale, it's a little bit more self-explanatory. You hold up that particular picture and you ask the patient to point to the face that they are currently feeling. Patient and family education. The nurse provides education to both children and their families. It needs to be age and developmentally appropriate for the child. Nurses need to assess for learning readiness and ensure that needs are tailored to the individual. You guys will actually have an assignment in your lab course that involves creating a teaching for a child of a school age developmental level. And last, child development, privacy, and confidentiality. Privacy measures must also be taken with respect to the physical examination. And the older the child, or if they're an adolescent, they may request confidentiality of some clinical findings and even diagnoses, such as a positive STD test. For example, for our adolescent population, if a client wants the parent to step out of the room during the assessment, we have to allow them that right. Respecting the privacy and confidentiality of pediatric patients may create some tension for nurses when they experience a sense of conflict between duties owed to the child and those owed to the parent, because those don't always align. In certain circumstances, the healthcare provider is legally required to break confidentiality, such as in circumstances in suspected abuse or threats of self-harm. As a pediatric nurse, we may want to offer a medical chaperone to be present during potentially sensitive circumstances, such as exams or procedures involving exposure and or touching of breasts or genital anal areas. Exams that involve children or parents known to be anxious, suspicious, seductive, mentally or cognitively impaired, as well as obtaining a medical history that requires detailed questions of a sensitive nature, such as a patient that has a history of sexual abuse being asked questions of their sexual history. We're all familiar with HIPAA, but one of the things that we utilize in the pediatric world are privacy passwords. Privacy passwords may be used in the case of custody issues or suspected child abuse, where health information privacy needs to be protected from unauthorized individuals. At admission, we want to have parents select a personalized password. Instruct them to share this password only with persons with whom they permit staff to share the patient's personal information. Remind them that they will need to remember the password when calling from outside the hospital, and record this password in an easily retrievable section of the medical record in a protected area at workstations. Decision-making in pediatrics is complex and involves a variety of considerations. The best interest standard is a standard in which decisions are made based on the child's best interest, which may seem easy in theory, but can be a bit more complicated in situations where there is a disagreement in healthcare. Now, this can be a disagreement between parents, so mom and dad disagree on what they want for their child, a disagreement between the parents' wants and the child's wants, or a disagreement with what the healthcare worker thinks is best and what the parent thinks is best. We also want to consider the role of parental religion in best interest determinations. We'll talk about this a little bit more when we go over chapter 4, which covers culture more, but it is important that we try and incorporate religious practices in patients' care when it makes sense and it's not going to negatively impact the child. We also want to partner with the child in decision making when they can and when it makes sense. It is the parent or caregivers who have the ultimate ability to make medical decisions for their children. However, it does not mean that children should have no role in the decision-making process, especially as they get older. As children begin to grow up and their capacity for decision-making develops and matures, they can and should become more actively involved in promoting their own healthcare because they're going to turn 18 one day and they're going to be responsible for their medical care. So the sooner that we can get them involved, the better. And finally, advance directives. Minors are not qualified to draw up formalized advance directives that have guaranteed legal standing. However, discussions concerning their wishes should be held from time to time, especially when children are older and have chronic or life-threatening conditions. National patient safety goals are issued by the Joint Commission to help improve patient outcomes and are updated annually. Some of the more common ones that we see in pediatrics are going to be our 2 patient identifiers, fall reduction standards, and medication safety standards. For our 2 patient identifiers, these must be checked, so the patient's name and date of birth, every time a patient is admitted, transported, transferred, or discharged, every time a medication or blood product is administered, every time a lab specimen is obtained, every time a procedure is performed, no matter how long the patient has been known to the nurse or admitted to the facility. So it's very important as the nurse that we make sure that our patients have their identification bands on. This is one of the first things that you should do when a patient is admitted to the hospital. Moving on to fall reduction standards. So we have to think about our fall risk precautions. What are our fall risk precautions? So think making sure our patients have non-skid socks, making sure that they have a bracelet that identifies them as being a fall risk, a sign either outside of the room or over their head of the bed, making sure that they're ambulating with assistance. Children present with special challenges for fall reduction, especially our younger kiddos, because think about our toddlers. They're learning how to walk, so they're not as stable on their feet. Or they're rambunctious, they're getting out of bed, they don't know their limitations. So these fall risk standards really, they really hit home for pediatric patients because they're at an even higher risk for falling. And last but certainly not least, we have our medication safety standards. So some of the most important considerations when thinking about medications for children are that Children's medication dosages are largely based on formulas that involve the child's weight and or their body surface calculations. This adds opportunities for errors in dosing, such as wrong weight or wrong height, wrong formula, and math errors. So it's very important that we get an accurate weight on the child because the medication is being dosed based on the patient's weight. Children's medications also come in a variety of formulations and strengths, presenting additional opportunities for error in preparation and dispensing. Infants and young children will not recognize that the wrong medication is being given, and some older children who suspect something is wrong may not feel like they can challenge adults by questioning why the pill is a different color or why there are 2 pills instead of 3. So it's important that we recognize this population as being more vulnerable to medication errors. And furthermore, children may be unable to communicate symptoms of adverse reaction, so they really must be monitored closely for more objective signs and symptoms. Last, medication safety precautions. Pediatric nurses can help ensure medication safety with one of the following measures: reconciliation of medications given at home with those given in the hospital, as well as reconciliation of medications given in different areas of the hospital when the child is transferred. As a pediatric nurse, you will have to advocate for your patients. Advocacy entails speaking up on behalf of those who cannot speak for themselves and helping to further empower those who do have a voice. Prevention, detection, and treatment of child maltreatment are a major advocacy focus in pediatrics. We must monitor for any signs of physical, sexual, emotional, or medical abuse, as well as neglect. We'll go over a little bit more of what this looks like in Module 2. Healthcare providers are mandatory reporters of child maltreatment and cannot be held liable for good faith reports, but could suffer legal penalties for failing to report to law enforcement or the appropriate children's service agency. It's not always black and white when it comes to possible child maltreatment. There are issues of ethics that emerge when dealing with these types of cases. It can be difficult to decide how much of a concern warrants a formal report to the authorities in the absence of clear proof. Even if a family is cleared following the medical or social services investigation, the fact that a report was made remains on the books, so reporting is a serious step that should not be taken lightly. And especially as a new nurse, you're going to feel overwhelmed and not sure what to do or if you're making the right decision. So just be aware that you're not alone when it comes to advocating for your patients, including your clinical supervisor, charge nurse, social worker, provider, and other members of the healthcare team in your concerns so that you are including them in the plan of care. It's not just you that has to be involved with your patients, it's everybody. So going to them when you have a concern, especially for a concern like child abuse, is extremely important. Family plays a very important role in the world of pediatrics, so it is important to understand what that entails. A family consists of 2 or more members who interact and are dependent on one another, socially, financially, and emotionally. Family types and functions can look very different from one another, as there are numerous family types and structures. Families provide for a child's physical needs such as shelter, food, water, clothing, as well as economic needs. Beyond these basics, families also provide nurturing, a sense of love and belonging, financial organization, and boundary management. Nurses should be aware of family dynamics that may affect communication, as well as potential stressors that can make it harder. It is always important to assess any of these stressors. An example could be a recent loss of a loved one, employment constraints or unemployment, lack of outside resources, etc. When children are hospitalized, families can have a range of emotional reactions to learning their child has an acute or chronic illness. These may include denial, frustration, fear, anger. It's important as the nurse to assist families to help support them by having open communication and allowing the parents to maintain home routines as appropriate, providing positive feedback, telling them that they're doing a good job, and preparing or educating the family and child for what's to come, as appropriate, of course. Communication theory states that all living beings communicate, although the manner of communication can differ. The way families communicate with each other can either create a healthy family dynamic or an unhealthy family dynamic. Think back to your own family and kind of consider some healthy ways in which your family communicate and some unhealthy ways in which your families communicate. Nurses may need to conduct family assessments to gather information on stressors and relationships for the family as a whole. When the child is first admitted, asking questions such as who lives at home, does the family need any help with any insurance, finances, shelter, food, etc.? How do they interact with one another? And what are everyone's roles? These questions will help the nurse determine not only how to approach the family, but also help identify risk factors and what resources may be needed. Some tools that may be utilized to conduct a family assessment include a genogram or a kinetic family drawing. A genogram is a diagram illustrating a person's family members, how they are related, as well as their medical history. This is typically something done by a caregiver, whereas a kinetic family drawing is used to understand a child's self-concept and interpersonal relationship between their family members. So it's actually the child that will create a picture of their family, and then they'll be asked to explain it. We don't really utilize these formal assessments as peds nurses. It's more of a social work, psychologist, psychiatrist area of expertise, but it is important to know what they may look like because they may be conducted in the hospital. Communication in the pediatric population is going to vary based upon the child you are caring for. Nursing communication for infants includes incorporating the infant's routines, such as feeding, changing, and sleeping schedules into their nursing care. Quickly responding to the infant's needs, providing developmentally appropriate toys or music to the infant. You can ask Child Life to help you out in that area. And your communication is primarily going to be with parents or caregivers. For our toddlers and preschoolers, we'll need to include a lot of praise, potentially offering rewards or a small prize such as a sticker or a small toy for completing a hard task such as an IV insertion or NG tube insertion. Medical play might be utilized to help demonstrate how a procedure will take place. We also want to utilize appropriate language. Children at this age will take things very literally. If you tell the child you're going to give them a shot, they might think you're actually going to shoot them. So you might want to use younger language, like I'm going to give you a poke. When communicating with school-age children, we want to allow the child to participate in procedures safely, such as taking off an adhesive bandage or depressing a blood pressure cuff. Allow the child to voice his or her concerns, encourage them to ask questions and answer them honestly yet simply, and allow the child to have time to play, explore, and have fun. And lastly, for communicating with adolescents, this is going to be more similar to your communication with adults. However, they're developmentally still immature, so we want to be mindful of that. We want to use more open-ended questions, provide privacy when appropriate, and actively listen to them. As nurses, we need to consider the client's culture, spiritual beliefs, values, traditions, behaviors, and environment, as well as how these factors may impact care to provide optimal outcomes. To provide care that is culturally competent, nurses must be aware of their own belief systems and identify the belief systems of the clients and caregivers. Culture also serves as a template for evaluating the patient's and family's psychosocial needs. When these needs are met, the client is better able to participate in care and focus attention on individualized health education. In nursing and in healthcare in general, cultural bias may occur, especially when the nurse places his or her own values before the values of a different culture. Nurses must examine how their own belief system may influence the care that is provided to prevent bias from occurring. And it's not necessary for you as the nurse to agree with a client's cultural or spiritual beliefs. However, you and the healthcare team as a whole must respect the belief of others. Environmental considerations are another aspect of providing culturally competent care. A client's home has a substantial impact on his or her health outcomes. It influences how care is delivered, the types of food available, how medication is stored, whether the patient has privacy at home, and countless other aspects of well-being. It is important as the nurse to assess factors in their environment, such as the family's employment status, access to outpatient services, as well as their socioeconomic status. To create a culture of comparable access and equitable care for all patients, it is important to recognize the disparities and inequalities first. Health disparities include social and economic status that adversely affect groups of people who have systematically experienced greater obstacles to health based on their religion, their age, their mental health, if they have any cognitive, sensory, or physical disabilities, as well as their sexual orientation or gender identity. Effective cross-cultural communication requires the healthcare team to communicate with each patient and family in a manner that is well received within their culture. To develop effective communications with clients and families of all cultures, nurses should learn about interacting with diverse cultures, know who is responsible for making health decisions for a patient, especially in pediatrics, identify the patient and the caregiver's perceptions of the cause of the illness or health alteration, because it may be impacted by their culture or their beliefs. Determine whether the gender of the care provider can affect the patient's care. This is important because there are certain cultures where they prefer or they will only have same-sex providers go into the patient's room. And be aware that silence, eye contact, body language, and touch can mean completely different things in different cultures. For example, eye contact in Native American cultures is not something that is routinely given. So if you're taking care of a Native American patient and you're speaking to them and you're giving eye contact to them, they may take it as a sign of disrespect and they may not give you eye contact back. It doesn't mean that they don't respect you or they don't want to hear what you have to say. It's just a part of their culture. A therapeutic nurse-patient relationship is based on mutual respect and trust. Pediatric nurses should take these best practices into account. We need to do things like keeping information confidential, making sure that we have developed mutual respect, recognizing that you are developing a new relationship within a different culture, treating patients as unique individuals and not just a one-size-fits-all box, and treating all patients equally. Another aspect of cross-cultural communication are language barriers. As a nurse, language barriers are something that you're going to come across in all aspects of healthcare, but you see it in pediatric nursing as well. Language barriers include any circumstances in which the sender of communication and/or his or her message is not accurately understood by the intended receiver of communication. In not so technical terms, one party doesn't understand the other party. Working with an interpreter is the best way to avoid confusion or anger. Always speak directly to the patient or family and not the interpreter. So some characteristics and behaviors determined by culture. We already talked about personal space, eye contact, and touch. Some of the other ones include diet, time perception, as well as the use of alternative medicines. In regards to diet, certain cultures may eat meals that are not available in the hospital setting. So we want to encourage, only if appropriate for the child's medical plan and diet plan, for the family to bring foods for the child that they are comfortable with and more likely to eat. We also want to encourage families to eat together to promote normalcy and socialization because that's what they do at home. With time, in certain cultures, time perceptions may vary. Personal time may be required for prayer in certain cultures and religions. And preferred times for visitation may not be consistent with visiting hours, which can present difficulties. Some cultures may prefer the use of alternative medicines. These alternative medicines and treatments, proposed or currently being used, should be discussed with the multidisciplinary team. Treatments should be accepted if they will not harm the patient. However, there are alternative medicines that are contraindicated with certain medications procedures. So we just want to touch base and ensure that it's not going to cause the patient more harm before we allow the family to continue utilizing those alternative medications or therapies. The cultural assessment is a mechanism through which the nurse gathers subjective data to identify beliefs and values of the patient's culture. The cultural assessment is typically something that we like to do at intake, so when the patient's first admitted. And this information is typically gathered from the caregiver of the child. Questions that you might ask during a cultural assessment might be things like, what language are you most comfortable speaking and reading in? What is your religious preference? Do you have any dietary preferences related to your religious or cultural beliefs? What home remedies might be used? What do you think the nurse should know about your culture while your child is hospitalized? Who makes the decisions in your family? And is your culture known for any special customs, holidays, rites of passage, foods, etc.? There's obviously more questions that you can ask, but these are just some of the more common ones just to get a better idea of what the patient's cultural and religious beliefs are. It is the nurse's responsibility to become familiar with these religious beliefs and try to accommodate any special requests as long as it doesn't impede with their care. The last chapter that we'll be going over in Module 1 is Chapter 5, End of Life Care, which talks about death and dying. Death is defined as the end of sustainable life. For infants and pediatric patients, death is the end of a short life caused by a terminal illness or disease. A terminal diagnosis can result from either trauma or a physiological cause. So trauma, think car accident, child abuse, or a physiological cause, so think cancer. Routine nursing care in pediatrics differs from end-of-life care in pediatrics based on the hospice needs of the patient rather than the treatment of a diagnosis or disease. The goal of hospice care or end-of-life care is a peaceful death rather than a continuation of a healthy life. When communicating with the family of a dying child, nursing assessments should be conducted to determine how the family unit functions, understand the level of information the family desires, what do they want to know, what do they not want to know. determine the family's overall understanding of the patient's diagnosis and potential outcomes. I would say that this is the most important one. Before you jump into telling them anything, you want to gather what they understand about what's going on before you start telling them a bunch of information, because they're already extremely overwhelmed. So you want to get a baseline of what they're already familiar with, what they already know. End-of-life care should also be family-centered, just like in all of pediatrics, but especially at end-of-life care. Family-centered care is the basis for all interactions of the family of a patient who is receiving end-of-life care. Communication with the family should be compassionate, cognitively appropriate, and based on the healthcare provider's assessment. So it's going to be individualized based on the patient's needs. Hospice care for pediatric patients is provided at end of life to promote patient comfort and family involvement. It promotes a graceful, natural death rather than attempting to prevent death with treatment. The patient with a terminal illness diagnosis receives compassionate care focused on his or her comfort with as few invasive devices and procedures as possible. Hospice care can occur on any unit of the hospital or even at home with visiting nurses and care aides. The initiation of hospice care is generally done by the physician with the input from the multidisciplinary care team. This multidisciplinary approach is essential for successful hospice care and includes many members of the healthcare team, such as the case manager / social worker, a child life specialist, the physician, pharmacist, nutrition, and pastoral care if it's needed. Pain control is another important aspect of hospice care and is the job of the nurse, physician, and pharmacist. So they all work together to come up with a good pain control plan for our patients. In end-of-life pediatric care, pain is defined as any uncomfortable feeling that prevents patient relaxation or rest. Pediatric pain can manifest very differently from adult pain, with symptoms that are very different from adult pain symptoms. Pediatric pain assessment techniques include using their vital signs, what their position looks like, and the parent or caregiver input. Using the FLAC or FACES scale would be appropriate in these situations. Pain control methods include both pharmacological and non-pharmacological methods. And lastly, we also want to keep in mind any cultural considerations of these patients and their families, providing them culturally competent care so that the nurses are incorporating their beliefs into their daily care as appropriate. Nursing interactions with children at the end of their life should be based on the child's developmental level as well as their cultural needs. You want to try and get the patient to explain to you their understanding of death. A child's view of death is based on their developmental stage and life experiences, so expect a varied behavior and opinion related to death. In providing family-centered care, the nurse must incorporate the families and siblings as well in these conversations. But depending on the sibling's age or developmental level, they may not be able to comprehend it as well. So this again is where a good spot for child life specialists to come in and help communicate with them and help them grasp and understand what's happening to their sibling. Grief is inevitable when it comes to end-of-life care in children. There are many different theories on grief. However, one of the more popular ones that we use more in healthcare is the Kubler-Ross theory on grief. That's the theory that has 5 stages: denial, anger, bargaining, depression, and then acceptance. So typically, we start off in the denial phase. So there's a refusal to believe that an infant or child is dead or dying. Then we move down to anger, which we may see anger or aggression towards staff or other family members. Verbal arguments and confrontations are common in this stage. Move down to bargaining, which is an attempt to create a change in the situation through an agreement for services exchanged. Then we move down to depression. So, caregivers, family members, patients themselves are crying. Maybe they lose their appetite. Family and friends may withdraw themselves, especially from the patient. We see that can be common. And then finally, acceptance. So to receive or agree with what is offered, to come to terms with the event and the associated loss. It's important to understand that grief is individual. Family members may grieve at different stages, and not everyone will grieve in the same manner at the same time. The family should be educated that this may occur and is normal. Staff feelings of grief over a loss of a patient are common as well and should be expected and addressed as a normal reaction to the loss of a pediatric patient. When providing nursing education and end-of-life care, it is important to assess the family and child's prior understanding of the diagnosis, prognosis, as well as what hospice and palliative care entail. Once we've obtained that baseline assessment and we have an understanding of what they know, there are some things that are just good for nurses to educate their families on. These are going to be things like explaining the cause for the patient's terminal diagnosis and how the disease will cause death, explain the current medical interventions needed and what the patients should expect with them, what to expect during the dying process in terms that are appropriate for the child or siblings, as well as the parents and family members. Every child's death experience will be unique based on his or her underlying diagnosis, but we do want to ensure that parents and family members are educated on the decline that will occur, including any physical changes that they might see, such as cool or mottled skin, swelling, altered verbalization, swallowing difficulties, abnormalities in breathing pattern, and an altered state of consciousness. We want to explain to them what to expect at the time of death, such as how the child will look, what the staff members are doing, and who the family wants in the room. And then we also want to educate what to expect after death, so how they would care or where they're going to take the body after the patient passes, as well as funeral arrangements. Family presence in pediatric code situations is handled differently in all hospitals, so it's important to understand the hospital-specific guidelines. Some of the considerations to think about when including a family in a code situation is that having family in a code does provide family-centered care, especially in a stressful situation. The desired outcome of family-centered care in pediatric code situations is to create greater communication and decrease confusion for the family. This can be positive because the family knows that everything possible was done to save the patient, but the negative aspect being that the family sees the child in the worst situation possible. So it's kind of a gray area. There's not always a right or wrong answer to this question. However, if the family wants to be present during the code, we should allow them to do so. Withdrawal of care occurs when the family decides to stop all life-saving measures and allow the infant or child to die naturally with the family at the bedside, rather than an end-of-life attempted resuscitation with the child surrounded by medical staff. Parental rights in withdrawal of care allow them to consent to end interventions and determine when the interventions will be stopped. They also have the right to change their minds and continue care. Initiation of withdrawal of care is determined by the condition of the patient, the physician's opinion, as well as the parent or caregiver's desires. When we are withdrawing care on a pediatric patient, some of the nursing interventions that will be Included in withdrawal of care include turning off the monitor, disconnecting all invasive lines, creating a more comfortable, undisturbed, peaceful, and private environment for the family, as well as meeting any of the needs of the family. Family involvement in the daily nursing care of the dying child will be different for all families, but when appropriate and desired, the family should be involved in all aspects of their care. We want to allow family to hold the child or lay in the bed next to the child if it's appropriate, wrap the child in a warm blanket if necessary. When it's time to say goodbye, there are a lot of memory building things that we can do, including child life in this process is very important. Some things that we see child life do with families of a dying child include making handprints or footprints created using molds or ink, obtaining a lock of hair and placing it in a bag, taking pictures. Some hospitals provide a camera for staff to take digital photos, and sometimes they'll even hire a professional photographer. When appropriate, assist pastoral care in meeting the spiritual needs of the family and the patient. And last, proper documentation at time of death is the responsibility of the nurse, ensuring that all care, all nursing interventions, patient outcomes are documented thoroughly in the child's medical record. Organ donation is the giving of viable organs from a dying patient to patients in need of specific organs. Pediatric organs can actually be transplanted into adult and pediatric patients. A patient is considered a viable donor when the organs are not damaged by disease, trauma, or medication. Not all children who die are candidates for organ donation. It is a pretty lengthy process with a lot of protocols that must be rigidly followed. When the time for the conversation of potentially donating an organ comes, the family is typically approached by an organ donation team. They are specifically trained in approaching families to request that they donate the patient's organs, so it's not going to be you as the nurse. Consent is needed from the legal guardian for organ donation. This is a very big one. Once consent is given, blood is drawn from the patient to determine the patients on the transplant list who would be the best match for the organs available. Procurement of organs is commonly done by the transplanting team, the transplanting surgical team. The team travels to the site of the organ donor and the patient is taken to the operating room to remove the organs. Parents and family members will have to say goodbye to the patient before transferring them to the operating room, and the patient does die in the operating room. Before we get consent from family to do or participate in an organ donation, we want to make sure they're very well educated on everything that this process entails. Some of the most important things include how the patient is kept alive via medical intervention until the procurement surgeon arrives, that the infant or child will pass away in the operating room, and the fact that the family can't be there. Sometimes this is a really big deal breaker for families because they can't imagine their patient's or their child's last breaths not being with them. So that can be a really big deterrent from donating their child's organs. But we also want to explain the benefits of organ donation to the recipient. Autopsies can be requested by the family, the physician, and/or the coroner. It's important to note that autopsy policies and procedures do differ by state and facility, so it's always important to check first with those. Families may request an autopsy if they wish to know the exact cause of the child's death. If the coroner doesn't agree that an autopsy needs to be performed, the family actually may be responsible for the cost of the autopsy. Physicians may request an autopsy to be done if the patient's cause of death is not known or unclear. However, if the coroner does not agree with that need for an autopsy, the family may need to give consent first. And then the coroner does have a legal right to request an autopsy in any suspicious or unexpected death situations and does not need consent of the family if it is considered legally necessary. Other legal aspects of pediatric end-of-life care are DNR orders. Some terminal children will have a DNR order, just like in adult medicine. This order must be respected. However, the nurse should be aware of the following: that all facilities have specific policies relating to DNR orders, so be sure to follow that policy to that specific facility. Only the legal guardians can determine a minor patient's DNR status, so it can only be the legally authorized representative. This DNR order can be reversed at any time by the legal guardians. DNR orders can range, they can vary from no life-sustaining interventions at all to partial or limited life-sustaining interventions. Some of the more common ones that I see in a pediatric facility are going to be they are allowed to provide oxygen or bagging, but no chest compressions. Sometimes they'll say oxygen only, or they can give medications, but no CPR. Typically, in the world of pediatrics, we do see DNRs that are partial or life limited. They're typically not no life-sustaining interventions. There typically has some sort of caveats to them. It's important as the nurse that you know if the child has a DNR and any specifications of the DNR. Parents and legal guardians need to be fully educated on all aspects of the DNR and what that looks like. And when a patient has a legal DNR order, it is the responsibility of the healthcare team to follow that DNR order. The person who is legally able to give consent for the child needs to be determined on admission based on facilities' policies and state laws. When caring for any infant or pediatric patient, nursing must ensure that the people giving consent for treatment are the legal guardians. It's one of the most important things that you do as a pediatric nurse when a patient first gets admitted.